ask Dan Thornton to tell us about the natural history and non-surgical treatment of thumb base OA.
Hi, morning. My name is Dan Thornton. I work over the Pennines in Leeds. I'm a hand surgeon in the hand unit there, and I'm talking, as we can see, about the natural history of base of thumb arthritis and non-surgical treatment. So we'll try and discuss what is base of thumb arthritis, how it comes about, what's the natural course of events that lead to the problems, how to classify it and how useful that is, diagnosis, and also treatment from a non-surgical perspective. So, osteoarthritis, I'm going to concentrate on osteoarthritis of the carpometacarpal joint, so trapeziometacarpal joint. I'm not going to go into STT joint arthritis with this, that's dealt with later on in this course. We're talking about degenerative joint disease, so it's a little bit false to determine whether it's just wear and tear degeneration or inflammatory disease, because obviously both inflammatory disease is also degenerative, and degenerative has an inflammatory aspect. So wise, it's the common degenerative nature, but there is inflammation associated with it. Increasing age, so this becomes more of a problem from age 40 onwards, progressively. There's a preponderance in the female population rather than the male population, it's more common. We all know that trauma across a joint, particularly following malunited Bennett's fractures at this level, can cause problems in earlier wear and tear type arthritis. A lot of the time we don't see the cartilaginous injury or understand that at the time of the injury because we're just going on our plain films. There's often a genetic preponderance as well, so patients may have a strong family history. From a large joint point of view, knees and hips, obviously weight is a significant issue, and double jointed or ligamentous laxity patients have a wider range of motion, and that can predispose them to these wear and tear joint related degenerative problems. So how does it happen? What happens? It's essentially degradation of the cartilage that then leads to ligamentous instability as a consequence of lack of joint space, and then subsequently you get bony changes. So if we delve into that a little bit deeper, what happens to start off with is you get dehydration of the cartilaginous matrix, and this causes erosion of the cartilage, the protection over the articular surfaces of the bone. You get inflammation within the joint, even in this degenerative arthritis, which causes swelling and can cause an effusion. And ultimately you end up with loss of joint space as the cartilaginous height and sometimes bony height settles. You get trapeziometacarpal ebonation, so these are the two raw bone surfaces rubbing on one another, where the bone ends become really shiny, and that looks sclerotic on the x-ray. As the joint shrinks, or the joint space shrinks, you get ligamentous instability, and probably across the carpometacarpal joint at the base of the thumb, the important ligaments, the anterior oblique or beak ligament, that basically seats the volar aspect of the base of the metacarpal in on top of the trapezium, adjacent to the base of the second metacarpal. You've got dorsal-radial ligaments as well, which prevent dorsal subluxation of the metacarpal base. But as that joint space reduces, what tends to happen is the APL tendon pulls the metacarpal base dorsally, so you get dorsal subluxation, and because of the loss of the joint space, that's not resisted either by the dorsal-radial ligaments or the anterior oblique ligament. So then you get problems because you've got less of an articular surface. Your metacarpal base, one on top of the other, you've got all the force over a smaller area, so then you get bone density shifts. So where we've got extra loading of the bone, we get sclerosis, and you can see on the x-ray there, in this sort of region here, that becomes a lot whiter where these bones are being impacted upon. And equally, where it's offloaded, you get cystic change. And the general inflammation associated with the arthritis causes osteophyte formation. Classification, well, we love classifications, don't we? They're useful if they help guide treatment. They're useful if we all know what we're talking about. With regard to the inter-observer error for Eaton Littler, this was first described in 1973, and then in 87 they added on or talked about STT joint involvement as well. So that's changed. There's not great inter-observer agreement in what goes on with this, and it's also a poor correlation for treatment. Some people have shocking looking x-rays and have very little problems in the way of pain or discomfort, and some people have pristine looking x-rays and seem to have a lot of problems. So it's difficult to know. We can't even agree on it. I think in the studies performed, they had 5 musculoskeletal radiologists and 8 hand surgeons. They looked at 40 different patients and only 10% could they all agree on the first course of action. The good news is the first course of action is always non-operative treatment. So how do we diagnose this? What's the problems? A lot of patients are asymptomatic, so we don't tend to see them. So lots of people have quiescent osteoarthritis at the base of the thumb, manage perfectly well and don't have problems. Increasingly then complain of pain, which can be an activity with firm pinch or grip, or if they knock or catch the thumb. And this, if as it gets worse, becomes more associated with rest pain. So after a heavy day, they run into more problems with it being difficult and painful and struggling with sleep. They have reduced range of motion, whereby things can feel difficult to move. So stiffness as well can slow down that activity, and their actual range of motion can also get affected. You do get an inflammatory element, so you do get swelling around there as well, and that can be soft tissue swelling due to synovitis and a joint effusion, and also you get bony swelling due to extra bone laid down and squaring off of the metacarpal base. Patients may comment on grating of the thumb and grinding when they're moving and using the thumb, and you may feel crepitus on examination. Investigations, still plain x-rays are our hallmark and go-to as regards examination, investigation of this. So treatment, universally, it's been accepted that first-line intervention should always be non-operative, and it really should be a tailored treatment, escalation of treatment with low complication and risk profile treatments first. So initially, you need to educate the patient. The Otter study that contributed to the BSSH best guidance done just over a year and a half ago confirmed that actually patient information, patients understanding what's going on in their hands allays a lot of fear, and then weight loss for large joints. Keeping the hand moving is important. Certainly good evidence that keeping it moving rather than resting it is the right way forwards. Activity modification, so not doing activities that are particularly painful, and simple adjuncts available online can improve things as well. Spring-loaded scissors, L-shaped knives, jar, ring pulls, all these sorts of things for the difficult activities that are painful can keep people functional, which is key. Medications next. Topical agents, so topical anti-inflammatories, ibuprofen, diclofenac gels can work very nicely. Don't have the same sort of side effect profiles as oral medication. Simple analgesia may be beneficial in the short term as well. Non-steroidals, not for prolonged periods because of the risk of respiratory or gastric problems. Splintage, certainly the benefits of splintage lie in resting the joint that's tender and protecting it and maintaining the first web space. When should we splint? Night splintage for night pain that interferes with sleep, certainly. Splintage during the day, really just with activities where it supports it and it's causing problems. Jury's out on hard or soft splintage, one over the other doesn't seem to be, so it needs to be individually tailored for individual patients because some people benefit more from hard than soft splints. Do we include the MCPJ? Again, no great evidence to suggest that it's any better to improve that, to include the MCPJ in addition to the CMCJ. Injection treatment now, corticosteroids to start off with, good evidence that that can improve it. Should we give them blind? Should we give them guided? In the case of blind sort of anatomical injections, about 2/3 of them actually go into the joint. Does that matter? Well, you get better intra-articular placement of the injections under image guidance, and the short-term results don't seem to be particularly different whether you do it blind or otherwise, but by 6 months there's a better result and a more prolonged benefit if you've done intra-articular injections confirmed by image guidance. How long should you do them? Lots of information, not a lot of consensus. On the studies here, and the advice here was if they give a reasonable benefit for 6 months, then they're worth repeating and continuing as necessary. Is there a limit to how many you do? I think the limit is more based on our individual work practices rather than any obvious risk of damage. Potential complications of skin pigmentation or fat atrophy. If you're running into problems with those, then I think you need to be holding back on things, but otherwise my threshold's usually about 3 months. If it's returning back to pre-injection levels, you find your patients are in pain most of the time waiting for the next injection, and you probably need to be thinking of something further. Hyaluronic acid, more really in the large joint studies at the moment. It's not really recommended for CMCJ or approved by NICE at the moment, but that might change subsequently. It's important to know about other complementary medicines. Your patients will know about them. Your patients will ask you about them. So glucosamine is a natural substance in ligaments, tendons, and cartilage. It's derived from shellfish, so it's important to know about patient allergies, but it's probably not something that we'd be prescribing. May be beneficial, and the improvement usually is fairly early on, within a couple of months. So if you've not really had any improvement, and it's mainly for large joints, within that period it's probably not really helping. Chondroitin, again, provides elasticity in cartilage. It's a natural substance. It takes a long time to effect, over 2 months, so you've got to keep going. If you've got severe X-ray changes or severe damage, it's probably not going to do the job for them. Fish oils, there's some evidence in rheumatoid arthritis that it can decrease levels of pain there. Complementary therapy, patients try lots of stuff. I think it's fair to say that the evidence for any of this is mild to non-existent, but actually, you know, the placebo effect and patients taking control of their treatment of basal thumb arthritis, it's all part and parcel and tailored to the individual. These are your friends as the physician rather than otherwise. So if you've got patients that swear by these techniques, that's all right. That keeps you from giving them lots of progression on to more complex problems and mischief. So I wouldn't poo-poo any of these on the basis of them coming and saying it works. Some stuff works for some people, other stuff works for others. So these are your friends, and not to be shirked. And that's the end.
Perfect timing. Thank you very much. Now it gives me great pleasure to call Soham back to the lectern to talk to us about trapeziectomy. And Joris needs to listen carefully to this because I'm not sure he's ever seen one. So.
Very good. So the trapeziectomy is still the gold standard. Well, it was first described around 80 years ago by Joris, and that was his level of evidence. Most patients were satisfied, left the thumb a little bit weak, but most of them did very well. So 8 years on, should we still be using this as the gold standard? So what I would like to do is look at some of the evidence. So the evidence is as good as the studies that produce it. So this is our risk of bias table that we did for the systematic review for the guidelines. Lots of question marks. This is the Cochrane review. Again, similar question mark spread. So there's plenty of risk of bias, and evidence that we have is at best moderate. However, let us see what we do know about trapeziectomy. We know that trapeziectomy improves pain and function significantly compared to the preoperative state. We also know with reasonable certainty that additional procedures do not actually make any difference to the outcome. We also know that subsidence occurs, and lots of work and modifications have been done to prevent this. I'll deal with that a little bit in more detail at the tutorial sessions. But we know that subsidence is measured in various ways. And to summarize what we know about subsidence is that it occurs mostly in the earlier stages, stabilizes after about a year, and in general, patients will lose 50% of their preoperative trapezial height. Does it matter? There's no correlation between subsidence and soft tissue stabilization procedures. There's no correlation between the function, pain, functional improvement, or strength with subsidence. Severe subsidence will of course matter when it causes impingement. That is fortunately quite low. The rate of that is about 1 to 4%. So looking at it a little bit more in detail about the outcomes of trapeziectomy that we know from our papers. So it is measured variably. In general, there's significant improvement from pre-op levels. And those that are measured using the VS scale, a mild residual pain of 20 to 30, a 1 to 3 out of 10, it seems to be quite commonly present. So mild residual pain is common, but significantly better than pre-op. Likewise, function is measured in various ways. Those that use a dash score show residual dash of 20 to 30 out of 100. So that is, again, mild dysfunction. It's important to note that long-term studies show that this improvement in pain and function that is achieved after a year seems to be maintained. Grip strength, there's a modest improvement, but there is some evidence to show that grip strength does actually reduce in the longer term. And these graphs is from our study for the long-term results of trapeziectomy, and it shows that after 5 years, grip strength does reduce. So the blue ones are the affected thumb, the orange ones are the non-affected contralateral thumb. Both of them show reduction in grip strength. So whether the grip strength reduces because of the chronological age changes or because of the trapeziectomy is difficult to know. I suspect trapeziectomy has something to do with it. Range of movement is universally preserved. There's never really a problem with range of movement, and it generally maybe a little bit improvement in abduction extension in some studies. But we have to be holistic. Does trapeziectomy improve quality of life? This is from our registry, and this shows that EQ5D and the PEM Part 2, they do actually improve. A total hip replacement, which is a life-changing operation, improves by 45 points. Compared to that, plus 15 is actually pretty good. Complications. Trapeziectomy appears to be a safe operation, and generally the tendon and nerve-related complications are common. They are minor, transient. Severe complications are rare. Now, there's some evidence to say that LRTI, because we are doing more surgery, may increase the complication rate slightly. Now, this is a systematic review looking at complications for a large number of trapeziectomies followed over a minimum of 5-year period. And this shows that in general, again, transient minor complications with tendons and nerves. Subsidence is quite low, about 3%, and reoperation for any reason, including subsidence, is also quite low, about 1.5%. There's been more literature on the complications, and this is a very large study, a 19-year study of 35,000 trapeziectomies. And again, it shows that systemic as well as local complications are extremely rare. So it is a safe operation. Reintervention, again, the same as Hestater paper, which shows that reintervention by way of steroid injection following trapeziectomy or indeed reoperation rates are very low, somewhat higher with arthroplasty and arthrodesis, so around 1%. We always worry about younger patients with trapeziectomy, and there's some evidence to say that patients less than 55 years have a worse outcome. So this paper looked at that specific group of patients who were less than 55 at the index operation. In general, after a mean of 11 years, most of them have maintained good pain scores, a VAS of 1. A proportion of them did deteriorate, so 17% had worse pain scores in the longer term, and this worse pain scores correlated with the time since surgery. So about 17% deteriorate in the longer term if they were 55 or less at the index operation. We also know that trapeziectomy has a long recovery time. I always tell my patients that it takes at least 3 months to get back to using your hand normally, and I think that's universally what is true. So this paper looks specifically at return to work, and in an average, patients return to work at 12 weeks, but most of them return to work at 12 months. And this depended on what kind of work you do, what your hand dominance is, and how your other hand is. So generally, it does have slow recovery time, there's no doubt. So to summarize, significant improvements in pain from preoperative state, significant improvement in function, mild residual dysfunction, mild residual pain is quite common. Modest improvement in strength, deteriorates over time, range of movement is maintained. Complications are minor and temporary. Serious complications, such as impingement resulting from subsidence, is quite rare, and reoperation rate for trapeziectomy is around 1.5%. However, whether or not is the gold standard, which is the question I asked initially, depends on how it compares with other operations, and the main competitor really is trapeziometacarpal joint replacement, and I think it's a very close competitor. So looking at some of the evidence comparing the two procedures, I could find 4 RCTs. There's plenty of case series with excellent results, with 90% long-term survival with joint replacements. But just to make a comparison valid with RCTs, the studies are small in numbers, small numbers of patients with short duration of follow-up. So these two, as we've said, 62 patients, 1 and 2 year follow-ups. These two, some more patients with the dual mobility implants. Again, duration of follow-up is short. And this is a systematic review looking specifically at this comparison. And this shows that both procedures significantly improve pain and function from preoperative state. There is no doubt that trapeziometacarpal joint replacement has a quicker recovery and better early function. Even within this short period, however, they did find that at the 1 year stage, the functional scores seem to kind of even out between the two. But range of movement, grip strength, pinch strength, all of these seems to be maintained better with joint replacement. So in terms of, is it still a gold standard? I think at the moment, the current evidence would suggest it is so. But it is evolving, and 10 years down the line, this may be a different lecture. So I'd like to leave you with these quotes from Jervis's paper, which summarizes his findings, which I find quite entertaining. Thank you very much.
Thank you very much. An excellent talk, and a minute or two under time. Interestingly, Jervis ended up having his own operation about 10 years after he described it. So now we move to the future. Joris has come from Belgium, and there's very little he doesn't know about thumb-based replacement. So welcome, Joris.
Oh, thank you for the very kind invitation and a warm welcome. So I'm Joris Duerinckx. I work as a hand surgeon in Belgium, in Genk. Genk is not Ghent. So Ghent is a historical city. Genk is quite a small city in the east of Belgium, really close to Maastricht. It became bigger with coal mining, so we have a lot of manual workers, and they now all develop, or most of them develop osteoarthritis, which is good for us as hand surgeons. I have one disclosure. I'm a consultant for KeriMedical, which is a company that produces one type of implant, but I don't think this is relevant for this presentation. So this is me trying to prepare this presentation, but this methodology didn't seem to work well. So I had to find like a scientific way to try to look into the future. And I think we can use the Gartner hype cycle to do this. So the Gartner hype cycle describes how most new innovations evolve. So it all seems to start with an innovation trigger. Then they rise to a peak of inflated expectations. Then often there's a true of disillusionment. And if it's successful, the innovation will slightly climb up again on the slope of enlightenment until the plateau of productivity. And during this presentation, I will try to project the evolution of total joint replacement on this Gartner hype cycle. And then we can see where we are presently, and maybe it can also give us a glimpse of the future. So the innovation trigger was in 1974 when Dr. Jean-Yves de la Caffinière in France stole the idea or saw the good outcomes of the total hip replacement that was invented by the end of the 60s here in England by Sir John Charnley in Wrightington. And he adopted the ball and socket principle to the base of the thumb. So that he even called himself, it's a miniature total hip arthroplasty. So the first implant was cemented. It used, like in the hip, polyethylene cup that was cemented in a trapezium with a metal stem. But they only had one size, straight neck, and quite a limited range of motion of only 50 degrees, which is almost the same as the normal joint. And the results seem to be reassuring in the short term. So he expanded his portfolio with different stems, different sizes. And there was also a second company that jumped onto this invention, and they developed the Guépard implant. But soon they saw that the results deteriorated over time. There were a lot of loosenings, and this was probably caused by the cementation process, which is associated with heat, and then probably necrosis of the bone. But following the evolution in total hip replacement, there was a tendency towards cementless fixation. And the first uncemented implant was introduced in the 1990s, and it was the Roseland implant, again from France. It stuck to the metal and polyethylene principle, but it had a stem that was coated with HA. And this seemed to work well. He had a survival of 91% at 12.5 years. So here the expectations are really inflating that there could be a good solution in these ball and socket implants. And soon other companies jumped on this idea, and that was then the introduction also in the 1990s of the Arpe, Ivory and Maya implants. And all these implants had their specificities. For example, the RP implant was the first one to introduce angled necks, because until that time all the necks were straight. And the RP implant also had a much higher range of motion of 120 degrees. The ivory implant, for example, had the conical cup again, and it had the possibility to exchange the polyethylene, which was not possible with the other implants. It was touched before in one of the presentations about total joint replacement of the wrist, but following the evolution in hip, there was also a trial with metal on metal in the thumb. It was called the electroprosthesis, but it had really disastrous outcomes with severe cases of metallosis, a lot of loosening. And unfortunately, this implant has been used extensively across Europe, and this led to many publications of failing trapeziometacarpal total joints. So this gave a bad reputation to this procedure. And that's how this implant fell in the trough of disillusionment. But the long-term follow-up of these second-generation implants that were cementless and relied on metal and polyethylene, they were published then in the 2000s, and these seem to be reassuring. You can see here the outcome of, for example, RP and ivory in centers with a lot of experience, more than 90% survival at 10 years. And it seems then that these implants can have outcomes that are comparable to the most successful procedure in orthopedics, and that's the uncemented total hip replacement. So that's how the trapeziometacarpal total joint replacement slightly started to climb on the slope of enlightenment. Certainly with the introduction of double mobility 10 years ago, so the remaining problem was the dislocation rate of 5% with the single mobility implants. And 10 years ago, the concept of double mobility was again taken from the hip surgeons and adopted to the thumb. And thanks to this principle, the dislocation rate has dropped to 0.5%. Where are we in the present? The scientific interest in this procedure is at its peak. If you look in PubMed at the amount of publications regarding trapeziometacarpal replacement, you see there's an exponential increase of the amount of publications during the last years. And what do we learn from all these publications? That there are a lot of advantages in total joint replacement over alternative treatment options. I think the main advantage is the restoration of the anatomy. The trapeziometacarpal replacement restores motion, but it can also restore the length of the thumb. It gives a perfect reduction of the trapeziometacarpal subluxation. And as a consequence of the previous key points, there's also a correction of MCP1 hyperextension in many patients without the need for any additional procedures like a volar plateplasty at the MCP joint. Another advantage is the better biomechanical situation for the thumb. I think this is a really interesting article by Lionel Atlani from France. It's a biomechanical study. And he measured how much weight you have to put on the muscles of the thumb to achieve a certain key pinch. And it seems that after total joint replacement, the amount of weight needed is the same as in a native thumb. But after trapeziectomy and even trapeziectomy with an LRTI, you have to put much more weight on the muscles of the thumb to achieve a certain key pinch. So that means that total joint replacement creates a much better biomechanical situation for the thumb than any other procedure. And that's what we see also in clinical outcome, that the strength is easier recovered, is typically better than with the trapeziectomy. The aesthetical result is better because of the restoration of the normal anatomy. It's a less invasive surgery. We don't have to take out bones and tendons. We will also prevent mid-carpal instability because we don't have to take out a carpal bone, the trapezium. And patient satisfaction is typically high. It's typically more than 90%. It's also, now we know it's a multifactorial thing to achieve a good outcome. It's not so simple. You need a combination of a good indication, you need a good implant, you need a good surgical technique. We've been discussing the implant, so what do you need? You need an implant that is cementless, metal and polyethylene. It has to be modular, so you can adapt the implant to the anatomy of the patient. For example, you can choose different neck lengths, you can choose between offset necks, straight necks, and double mobility will decrease the chance of dislocation. Our indication nowadays is the Eaton stage 2 and 3. Radiographic STT osteoarthritis is not a contraindication as long as it's not painful. So it's important to do a good clinical examination to check the STT joint. And if you are in doubt, you can do a diagnostic infiltration or a SPECT CT scan. And you need a trapezium height of at least 6 millimeters because a cup of the implant has a height of approximately 5 millimeters. Surgical technique, many of the recent publications go into the refinement of the surgical technique. Now we can say we have an evidence-based surgical technique, and that's important to follow a course, to visit a surgeon with experience, and to read these articles, because we know that most of the early complications are not related to the implant, but are related to technical errors, and the learning curve has been estimated to be at least 30 cases. But I've done several of these implants and I still learn every time I do one. Presently, in several European countries, the total joint replacement is a mainstay of treatment. These are the official figures from the Department of Health of Belgium. And you see 10 years ago, of all patients undergoing surgery at the base of the thumb, 60% got an implant. And nowadays it's already 80%. So in countries that adopt this type of surgery, it takes over the other treatment options. So to come back to the title of this presentation, is trapeziometacarpal replacement the present or the future? I think we know it's not a new procedure. It has been improved over more than half a century. Presently, there's a lot of interest in it. In the countries where they started to use it, it quickly takes over the rest. So I think it will be a procedure that will not be lost in the future, but that will only become more important. Thank you.
Thank you very much, Joris. Now it gives me great pleasure to call to the podium Sumedh Talwalkar from Wrightington.
I'll use the laptop. Hi, I'll use the laptop.
So, do we have a question for Joris while Sumedh's setting up?
Hi, Joris. Do you routinely release the first dorsal compartment to help prevent dequervence?
It's been described quite often. We had it also in one of the series of the Maya implant that we published with the single mobility, that we had an incidence of 17%. But with the single mobility, we know that we lengthened quite a lot. There's a study of Jean Goubeau, also from Belgium, with the ivory. And he also noticed that he lengthened to gain stability with the single mobility, small heads, and he lengthened on average 5 millimeters. But in the group that did develop and did not develop dequervence, the lengthening was the same. So what we see now with the double mobility, when we dare to put them in more loose, that the incidence of dequervence seem to decrease. So we believe, or the gut feeling is that it has to do something with lengthening. But there are many other factors. For example, biomechanical study where we looked at the excursion of the tendons of the first extensor tendon compartment. It seems that the excursion increases after replacement because we change the biomechanical situation. For example, we proximalize the center of rotation in abduction at adduction. Maybe that can do something. Maybe anatomical variations that do something. And also what we see, typically dequervence develops between 3 and 6 months after surgery. And that's also the time point where from 3 months, we see that the strength is higher than before surgery. Maybe it's because the tendons are not used to the strain they have to withstand from that time point.
How often do you have to treat it?
Now it's much less common, and if we see it, we treat it as a typical dequervence with an injection, and if that shouldn't help, then a release.
Now,
Yep.
Sumedh.
Yeah. I'm sure we'll have lots of questions for you, Joris. So what I'm going to talk about is CMC joint fusion. So my practice has changed. It's changed a huge amount over the last 3 years post-COVID in terms of what we did with base of thumb. specifically in the younger people. So these are some of my conflicts of interest, and really it's the Arthrex bit that that is relevant to us. We've always learned, while we were training certainly, that you reserved arthrodeses in the younger individuals, people who engaged in pursuits that involved heavy loading. And as you got older, you could do something which was more from the point of view of arthroplasty related type of work, or excision arthroplasties, for example. And as you get older, your range changes. So that's another thing that happens, and that changes your practice. Now, regardless of what you decide to do, one of the things that you need to confirm with all these patients is that you're dealing with first CMC joint disease, and not a combination of CMC and STT joint. And perhaps Dan's going to speak a little bit about that later on as well. And you do whatever you have to do to convince yourself about that. If you have a good radiologist, you can do all this just on the MR scan. We tend to do a fair number of base of thumb arthroscopies, like we had Matt speak about earlier, in order to confirm whether or not there are changes. And you do pick these up on a regular basis, where x-rays are normal, scans are normal, and you do an arthroscopy and you can actually find quite a big sized lesion that was missed on all those investigations. All these patients would have a complete course of conservative management, so don't forget that. You need to splint them, inject them, make sure that they've got proper physiotherapy and analgesia, and then those people that come out of this sieve will then be considered for surgery. So in which individuals would I now consider fusion over arthroplasty is the question, because the number of people that we do trapeziectomies on has radically fallen in Wrightington. So if you have someone who's younger, who's physiologically from an age group where they're doing, or they want to do more out of their lives, an absolute indication in my practice would be someone with a progressive neurological disability, or even someone like cerebral palsy, where by definition the neurological deficit is non-progressive. People who are in wheelchairs who are likely going to, essentially what they do is they walk on their hands is the best way to describe it. So individuals like that, certainly where I am with joint replacements, we're still in the lower hundreds. Until we come to the higher thousands like Joris, I think we probably will still take the safer approach with these individuals. The second group where I found with cases that I've inherited from previous generations are those with hereditary instability. So those who have instability, I still find that it's a bony procedure that involves fusion that tends to work well. So if you have an individual who has a base of thumb that clicks in and out and it's painful, regardless of the degree, at the moment in my practice, what I would do is I would consider a fusion as my go-to procedure rather than a joint replacement. And probably this is something that we could discuss. And the second group and the third group within the younger age group are those which do heavy to very heavy work. So their precise definition, these are not just adjectives, these are specific definitions under the industrial advisory group as to what heavy and very heavy work involves, and we can visit that later if you want. A special group are these individuals whom you see in your clinical practice with big hands, who do a lot of very heavy work. So these people, and these are things that I've discussed with Frederick and other individuals about the higher chances of wear. So remember, with the dual mobility joint, you're wearing the plastic on both joints. So use it more, you're going to wear it more. So these people are more prone to these intraprosthetic dislocations. And in cases like these, you give them the choice. And you have to make it very clear to them that if we were to do a joint replacement, you'll have a good result, you'll have a good innings, and it's more than likely that you will require a second procedure. And I make that clear to all patients who undergo this procedure, that say you do something like a fusion, the same rule applies for wrist replacements. If you do a wrist replacement, you have to tell them that a wrist replacement is not for life, regardless of whatever the MoTech people say. And certainly what we used to do with all our universal 2s and 3s was to tell them that this is a procedure which will require revision, maybe 10 to 15 years down the line, we'll have to fuse your wrist at some point. So you've got to make sure that they're aware. And then we come to the older age group, people who are not doing as much in life. And we had Adrian from Norfolk, Norwich Hospitals. He did an excellent talk on our Touch conference for the older age group. So when you have this sort of collapsed thumb, he does fusions in this group with good results. Now, he hasn't yet published his series, but we look forward to that. Little bit about the procedure. We use the lateral approach. You've got to make sure that you visualize this C. Now, we saw a lot of that yesterday during the cadaveric courses. We use a fine saw, and we use the V-shaped saddle of the trapezium to help us shape our osteotomy. And it's quite useful to take these out in these little pieces of bone, so that when you go back and you bring them together, they fit back perfectly. And it's important, and for reasons that I'll explain later, why you shouldn't try and exaggerate the amount of abduction. So hold that with the help of a K-wire, and I prefer using a plate. So standard T-plate using a combination of locked and unlocked screws is usually enough. Medartists have a fusion plate, which for whatever reason, somehow they haven't really pushed very far, but this is something we could perhaps use in a situation where you had a failed symptomatic fusion. Just a point about failed fusions is that non-union is usually very well tolerated. So within the group of people who have not undergone fusions within our group, we've had a number of people who are asymptomatic. So it almost functions like a Charcot joint. So a very small number come up for fusions. Little bit about the radiology. We discussed this yesterday as well. We are not radiographers. It's really important to be able to assess your fusion. So it's much nicer if you were to do something like a Betz view and learn how to do this in each case in order to be able to appreciate the anatomy around the trapezium. Because of the amount of overlap, it's very difficult to discern, whether you've put your plate properly or if you've not. Now, in your quest to ensure that you haven't adducted the thumb, very often what you end up doing is you end up opening the inside, the inner part of the osteotomy. And I think to a large extent, this is what causes the non-union. And why this is probably one of the reasons why fusions have had a bad press. Mike Hayton, one of my colleagues, uses the Dynamite staple. The Arthrex people, I think all of us are going to do the tightrope at some point. Hopefully they'll have this kit for you to play with. Now, this is a memory staple. It works really well. It's not licensed in the hand and the wrist. And the more astute people within the audience will realize that that is not a hand, that's a foot. You have this applicator, drill 2 holes into it. You have an application device, which essentially brings the ends of the staple apart. And after you've made these holes, you essentially put the staple in. And once it's in, the ends will close together, they'll coapt, and effectively what you get is a closure of the far part of the osteotomy. I really like this. You've got 2 sizes that can be used for the bigger or smaller hand. Simon Picard, he spoke. So one of the big advantages of working at Wrightington is I get the speakers to sign all kinds of documents, and I get hold of their PowerPoints. So Simon did a lot of these cadaveric courses for us using the Leibinger plate. He uses a Wagner approach. So this is slightly more difficult in terms of the anatomy because of the nature of the osteotomy. The logic is exactly the same. You get a very good view of the first CMC joint. The cuts are a little bit non-intuitive in my view, a little bit more difficult to do. And what you need is a volar approach as well as a lateral exposure in order to be able to place the plate. So you have to ensure that the thumb is positioned appropriately in space in terms of pronation, abduction, so that you can get a proper precision and key grips. What you don't want is too flexed a thumb, because they really complain about the ability to place their thumb flat. So that is what the Leibinger plate looks like, and he uses a screw to produce compression. So just to summarize, we avoid K-wires, not something we want to do. Plates can cause long incisions. There could be issues with compression. Increasingly, we find that staples probably are the answer. Seems to work really well. We haven't yet published our series yet, but we plan to shortly. As far as the screws are concerned, we could have problems with revision, and they don't necessarily always confirm well with the concavity of the joint. And this is how we perform the procedures. It's just a short summary of how we do it. The upside is very clear. You have a quick recovery, particularly in individuals who have very heavy jobs, as I described. It seems to work extremely well. And if it's done properly, you can have very high union rates. Few issues. The thumb position, this needs to form part of your informed consent process. You've got to ensure that they're very clear of the fact that they will not be able to lay their palm flat on the table. There is always the issue regarding non-union and the possibilities of them developing osteoarthritis in the other joints. So this is a very good case that Adrian presented, looking at the base of the thumb. So 20 years down the line, you can develop osteoarthritis in the STT joint, for example, and in this particular case, he was able to treat it just with the help of injections. So just a few cautionary notes. Make sure that you're very clear in your mind that the pain is coming from the CMC joint in the light cohort of people that I've sort of spoken about, and inform them of the ability to lie their thumb flat. And you do have a much higher union with appropriate internal fixation. Thank you.
Thank you very much, Sumedh. Masterly as ever. Now for the last talk of this session, I'd like to call Dan back to the lectern to talk to us about the STT joint.
Okay, so I've been asked to talk about STT pain, which will normally be due to STT arthritis. But on its own, it's a less common beast compared to the CMC, which we've been spoken about this morning. So when you're looking at arthritides or joint problems, it sort of falls into these four categories. And when we're looking at joint space narrowing, which is loss of cartilage, you can use this little algorithm. So does STT isolated on its own fall into a separate atypical bracket? Because fine if they've got CMC osteoarthritis, but my talk's going to be a lot about isolated STT osteoarthritis. We know distribution as well, so which joints are involved. On the left, we've got osteo, so definitely the DIPJs most commonly, sometimes the PIPs. Rheumatoid is going to be more proximal, more symmetrical. It's going to be PIPs, MCPs. Calcium pyrophosphate disease, pseudo-gout, is often in the MCPJs, and that's often the heavy manual workers on the index and middle MP joints, because that's not a classic GNOA sort of distribution, is it? But when we're looking at the wrist, again, we expect it in certain places. So in osteo, you'd get it at the CMC and the STT joint. In rheumatoid or inflammatory, you get it around the entire carpus, including the DIUJ. And then again, pseudogout is the chondrocalcinosis, SCAC type of wrist that you'll see at the radiocarpal articulations. But isolated STT osteoarthritis, if that's what it is on its own, probably has an incidence of about 1 in 7. Most papers count elderly as over 55, slightly depressingly. But it is associated with certain kinematic issues and shapes of bones, and we've got to realize that people are in the inside are as different as they are on the outside. When they've got a dorsal intercalated segment associated deformity, the lunate morphologies, the type A, type B, when they've got the facet for the hamate on the ulnar side distally, and if they've got thumb CMC associated with it. So anatomically, this is an old dissection, but if I go into it, so captate the undersurface of the trapezium, the undersurface of the trapezoid, and the trapezio-trapezoidal articulation here, you can see that there's actually a ridge here on the distal surface of the scaphoid, which produces 2 separate facets almost on that distal scaphoid. And that, from a very nice paper, which is well worth a read, divided the distal scaphoid articulation into these 2 subfacets, and then within that, 3 subtypes. So what we have is a tapered palmar facet, which is with the trapezoid for type A, more rounded but broad on both sides for type B, and you can imagine how an A will wedge fit distally as well. And then C is much narrower across it, which gives it more mobility. It can be confused, as Sumedh was saying earlier on, about you need to get the diagnosis right. And again, I agree with radiographic findings and symptoms we know don't correlate, but sometimes you can find MR is showing nothing. Plain films are showing nothing, so scoping this is always a good idea as well if you're confused or worried that you might go in to do something big, which you may regret. But differential diagnosis, it can be the CMC versus the STT. De Quervain's can sometimes mimic it. FCR tendinitis on its own or in association with STT osteoarthritis, the two can coexist quite easily. Infection and scapular instability. And the good thing, and what I say is the shortcut, is if you look at people's hands, you can see squaring off of the base of the thumb very easily. You can see that it's wide for CMC osteo. But you will find for both STT osteoarthritis and any radioscaphoid changes, they get quite significant dorsoradial swelling. And I've had lots of people referred in as ganglions that are very painful. So on the whole, ganglions aren't very painful. So you'll get dorsoradial synovitis associated with this STT and radioscaphoid changes. They'll have tenderness at 3 points. This STT is a very broad joint, so you can feel it palmally. So if you palpate up FCR, if you make a fist, if you do this, if you're not used to doing it, just radial to that is the scaphoid tubercle, and you can feel there's a little dip between the scaphoid tubercle distally and the trapezial ridge just beyond that. If you then take the wrist into radial deviation, it'll cause the scaphoid to flex, and ulnar deviation will cause it to extend. A little bit of volar pressure as you do that slight side-to-side motion in STT osteoarthritis will make them jump. Active passive assisted. The other thing that you'll find in STT arthritis is if you look at wrist flexion and extension, they'll have already lost a good 10-20 degrees on both ends of that arc. And they won't notice it because they've got a nice functional range, but those end range, they'll cheat it, and they do lose range because it's the mid-carpal joint that's blocked by this underlying process. I was really pleased to see that Sumedh was saying about imaging as well. If you ask for a thumb X-ray, the thumb X-ray will normally give you a very nice shot of the interphalangeal joint and the metacarpophalangeal joint. If you're looking for the CMC, you can and the STT, you can do these oblique views. The problem is when you've got STT osteoarthritis, that is a nasty position to go into. So what I actually asked for, so this is the images that you get from those, but they're quite difficult to get to. I normally ask for a DP and oblique and a lateral of the hand, because the advantage of that is that you'll find that the STT opens up really nicely and you'll be able to see that joint very well through it, but not on a thumb view, definitely. And the reason that you also want to have a look at the lateral of a hand is because here, this is a deep and lateral of the wrist that somebody was sent to me, but you can see how that lunate is already starting to extend because it's associated with that scaphoid, and often the scaphoid will ebonate under that undersurface of the trapezoidal joint and get incarcerated in there in an extended position often. Equally, steroid injections, you can do them from wherever you want. Going through the anatomical snuff box, you've got to be worried about going directly through or potentially injecting the radial artery. You can do them from a palmar aspect. Lateral view on an X-ray machine. Dan was talking about doing them under imaging. I think this is a hard joint to get into generally. Slightly pronate them, and you get to see what I call Kermit's mouth, which is the distal scaphoid and the trapezial ridge. You can get that in very nicely because there is a convex surface on the scaphoid and a concave surface on the trapezium, so you've got to get up and under that. And you can get reasonable distraction of that with joint injections, and they'll feel that joint stretch. And equally, the other thing I sometimes do once I've injected them is, can I reduce that lunate? So is it stiff distally and it's not going to reduce, or will you get a reasonable reduction? So once you've tried your 5 S's of management, which I think I've put it on before, it fits with S's, but it means activity modification. Simple analgesia. The people that say, oh, I can't take pain relief, just say, well, the things I'm going to do to you will definitely require you to take pain relief. Stretch and strengthening splints are therapy input. And a wrist splint for STT osteo is very good, actually. It does work. The evidence is variable for CMC joint, but for STT, they do tolerate that well. Injections, temporary, try before you buy. And then surgical intervention, which is what all we get excited about. So it basically breaks down into excision of distal pole of scaphoid, with or without soft tissue interposition / stabilization. Trapeziectomy plus the undersurface of the trapezoid. Interposition arthroplasty is described, which I'll touch on briefly, and STT fusions. So Mark Garcia-Elias did a very nice paper in 2011 talking about excision arthroplasty. Basically, he takes out the distal half of the distal portion of the scaphoid, and that is where it's important a direct screening to see how much you take and if there's any impaction associated through the full range of motion. He does a ligamentodesis as well, and then if the FCR is involved, we'll put an anchovy and give a static into position. The capsulodesis as well, but then you've got the dynamic element with the FCR, but it's distally based, so not necessarily that dynamic. But the idea is to stop that scaphoid going into extension, because you do get secondary degenerative change in the rest of the mid-carpal joint in about 1 in 6 people. And this is his technique. The reason people do it is it's technically easier, keeps the range of motion, and indeed, as Oliver was saying earlier on, if you get the mechanics right, then actually some people will come back with a better range of motion after an excision of distal pole. It's a shorter mobilization. It improves the grip from the few papers that I've looked through to about 20% and pinch 40% on average. At 2 years, 60% of pain-free, with 40% having a mild ache. But if you do have that extended lunate or proximal ray instability, it's probably contraindicated. This isn't my case, but I found it on the internet. I thought it was interesting that it had been put on. This person has had a relatively generous distal 2/3 scaphoidectomy and styloidectomy. And you can already see how that lunate on the DPV on the left has flexed up. And then they then put on that, then ended up with an intercarpal fusion as a result of that. So it's not without difficulties. In the probably dozen that I've done, it's a little bit variable as to who's happy with it and who's not happy with it. Some people have been delighted. Some people are like, the pain's gone, but I'm not sure I trust my wrist quite as much as I did. Matt gave a very nice talk earlier on about arthroscopic ways of doing things. You can do it arthroscopically and take that distal portion out. I'm not sure how easy it then is to screen dynamically and see if you've taken enough out of it. But again, the soft tissue envelope around it will have been preserved. Trapeziectomy, Sumedh as well pointed out earlier, the CMC fusion and the replacement is a monoarticular procedure. It will only deal with the CMCJ. It doesn't deal with the STT joint. So if somebody's got isolated CMC, we offer them a trapeziectomy on that spectrum. So why is it not good enough for the STT? You've got to do the heavy trapezoidectomy as well, but it's certainly useful, and Soham went over the pitfalls beautifully earlier on as well. Philippe Balmer has produced very good data associated with his paracardian interposition disc here. I've not done them myself, but I think the series from elsewhere don't necessarily replicate those good results that he gets, and obviously he's very much into that. STT fusion, again, gives about a 75% range of motion compared to what they started with pre-op. Most people, if you assess them pre-op, will have lost range of motion and don't realize it. I do think that's important to point out to the patients. They'll get 80% grip strength. It's discussed as being a high complication rate, with older papers saying 20%. As Sumedh was saying earlier on, obviously K-wires and the hardware have probably improved significantly since there. And recent papers have actually said it's up to 6% non-unions. This is a chap who was referred to me as having a lytic lesion in his distal radius. It was actually where they'd taken the bone graft for his previous STT fusion. I tend to take distal radius bone graft because I think that's part of the issue with non-union. If you don't graft this, because it's part of the mid-carpal joint proper, if you're trying to take this normally very sclerotic hard bone out, you're left with a big gap. If you then try and close that primarily, you're trying to open up the entire on the side of the mid-carpal joint, at which point it's a very hard thing to achieve. So I normally do an approach in line with EPL, mobilize it out of the way, continue down to Lister's tubercle, and often take a good sized chunk of bone graft there with precision bone grafting, and then pack that in and do percutaneous screws with cannulated. I use the Medartis one, I have no conflicts there. This is a chap who had his left STT fused by me. This is him at 3 months. And his flexions there, which was basically the same as it was. Interesting, since that time he's had the right side done, and at 8 weeks he did all that decking. So we thought that was a reasonable outcome for him. I mean, I told him not to, but he still did it, as we were saying earlier on. Equally, this is somebody that I did an excision of distal pole. He's a chap that really liked boxing, and he was worried about him losing his extension because he does lots of punch bags for training. He's getting a bit older now, so doesn't do as much. So when he didn't like it, we just couldn't get to the bottom of what he didn't particularly like. So he said, well, I need something stronger. So we did an STT fusion, a generous core taken. So you can see I've taken a core out of the distal radius, turned it 90 degrees and stuffed it around the side and really fused it up because I wanted it to work first time, given he'd already had one procedure. And he got back to boxing at about 3 months. He knows he's famous. As you can see from the exercise, that is his right hand. So I said, could you send me a video? And he did. So he got back to that level. There is a nice review paper from the American Journal. So they did 1,429 procedures. Only a couple of them came back for the opposite side, but it is unilateral. I have had a lady who have done STT fusion one side and now has CMC osteoarthritis with no sign of the STT being involved at that stage. Conversion to total wrist fusion was 4%, which I think is a reasonable thing. Secondary mid-carpal changes. Non-union was reported at 6%, mean flexion 40, extension 49, and the mean JMR grip strength was 75%, which is what I was saying earlier on. The other thing to bring into the STT talk is, we know SLAC, SNAC, SCACs and SMACs, but in 2020, unfortunately, a paper that was slightly buried by something that was happening in 2020, I can't remember what it was this very nice paper looking at a fifth one, just to add to your ACK list. So it's STT osteoarthritis advanced collapse, which obviously should have been called STAC, because then it would have fitted nicely, but there you go, can't have anything. But that's the QR code for that paper, so that's on free access, so you can open that up. But that's something just to be aware of, because that has a slightly different natural history compared to STT isolated osteoarthritis. Thank you. Any questions?
Thank you very much. We're almost into coffee break, but if I could call the panel up. Do we have any questions?
Joris?
A question for Joris?
Shall I just leave the microphone with Joris?
So in the patients that undergo CMCJ thumb replacement with asymptomatic STT, what's your experience in the middle long term? Do they develop symptoms and how would you manage that?
Good question.
So now we did 1,500 cases over 15 years, and we converted or had to do a secondary STT fusion, because that's what we do, is a fusion below the implant in around 5 to 6 cases. So the chance that an asymptomatic STT joint becomes symptomatic is quite low. Beginning of this year, there was a French group that studied specifically their patients where they did in pantrapezial osteoarthritis with an asymptomatic STT joint, where they did only an CMC1 prosthesis, and they saw the same result, that the STT doesn't become symptomatic. Lionel Atlani, that's the surgeon who did the biomechanical study with the weights at the muscles of the thumb. He also studied the changes in pressure in the STT joint before and after implantation of a CMC1 implant in cadavers, and the pressure didn't change at all. So the story that maybe an STT gets unloaded by CMC1 prosthesis is not true, but the implantation of a CMC1 prosthesis will also not increase the stresses at the STT. So if it's asymptomatic, there's no reason to think why it should become symptomatic.
I didn't quite get how you make sure that the STT arthritis is asymptomatic before you do the replacement. Because you said something about injection, but wouldn't it spread to the tissue?
It's a clinical examination, as has been discussed before. So we rely on pressure in the anatomical snuff box, pressure on the palmar side of the STT joint, and then, as a previous speaker has discussed, radial deviation of the wrist combined with flexion and extension. That seems to be a really good clinical test. Another test that was proposed by Jean-Luc Roux from France is to do resisted flexion. that seems to work quite well too. So you ask the patient to resist inflection, and then you put pressure on the FCR tendon. And that provokes pain also in patients with symptomatic STT osteoarthritis. If you're not really sure about clinical examination, then we do a SPECT CT scan, because that's easily available in Belgium. It's also, we can have it in 1 week, but I know it's not available in all countries so easily. But that really shows you if the STT is painful or not.
And if the STT is painful, then?
That's for us an indication for a trapeziectomy.
We offer patients with grade 4 arthritis replacement?
Only if the STT is not symptomatic. If you look at X-rays, patients with CMC1 osteoarthritis, some studies say like 48% have some changes at the STT joint. But if you look at the figures in Belgium, 80% of patients with CMC1 osteoarthritis get an implant. So that means that most of them are not painful.
Do we think that the Eaton-Littler classification is useful? Because what we're really saying is that the STT joint, which is part of a completely different joint, becomes arthritic at the end of CMC joint arthritis. So the analogy there would be that the end stage of hip arthritis is knee arthritis. So I don't think that the Eaton-Littler classification actually helps us. I think it overly confuses us. I think it's important we treat the two joints on their own merits.
I think that's Greg Packer's. You're comparing essentially hip arthritis with arthritis of the back. So I think you're absolutely right. I think a clinical examination works really well to differentiate STT from CMC arthritis. I don't have a problem differentiating the two, honestly. And our numbers aren't as high, but certainly we haven't had any issues. We've had a large number of our cohort who've had radiographic changes of STT arthritis. And we haven't had a situation where we've had to do that, any surgical intervention for the STT joint.
If you do have to proceed to an STT fusion, how difficult is it?
Just like a primary STT fusion, I like the technique that you showed with the 3 screws. We typically do 1 screw from the scaphoid, from the trapezium to the scaphoid, and 1 screw from the trapezoid to the scaphoid. So almost like the technique that you showed. And the height of the trapezium normally is more than 1 centimeter, and the cup is only 4 to 5 millimeters. So in the classical case, you have enough bone to put a screw. If that's really technically impossible, you could still do a trapeziectomy, but most patients like their implant and they don't want to get rid of the implant.
Do we need a bigger implant for big, strong men with thicker poly?
Yeah, the problem that we see with, so double mobility solved the problem of dislocation. What we have seen in 3 patients now is a fracture of the polyethylene in heavy manual labors with the double mobility. So that's 3 cases in 1,000 patients that we use the double mobility. We've been searching around in Belgium. We found 11 cases, and we will publish this year. It's the chance of a fracture of the polyethylene in double mobility implants, because I think that's the drawback of that type of implant, is the weaker polyethylene, because it's mobile, and I can imagine in certain positions of the polyethylene, when there's edge loading on that polyethylene, that you could break it. If you have it, the patients that we have seen it's in heavy manual laborers with a key pinch of more than 10 kilograms, and they were all males, so probably because they have a larger thumb.
So if there are no more questions?
Can I just ask one quick question to Joris? So essentially, why do you prefer fusion to a replacement? So something like what Philippe does, doing a pyrocardan under a touch. Is that not something you would prefer? Because from what you're describing, there's going to be very little trapezium left, and there'll be almost more metal within the trapezium than bone.
The problem is that the pyrocarbon is not available in Belgium.
Just a small follow-up on your comment about the fracturing of the poly head. How have those been resolved? Are they just replaced, or are you going for the single mobility?
So you have to listen to the history of the patient, because you don't see it on the X-ray initially. Because the polyethylene has a fracture, but it's containing the metal head well centered in the cup. So the 3 patients that we saw, they had a sudden onset of clicking of the thumb, and you can really feel the click when they start moving the thumb. And what we found was when you put traction on the thumb, then you see an eccentric position of the head. So if you suspect it, ask for traction x-rays of the thumb, and if you're quickly enough, within a few weeks, you can just change the head and the polyethylene. But one of my 3 patients managed to break the polyethylene again after 1 year. So I think it's a patient-specific thing too.
So, coffee beckons. I'd like to thank the panel for their excellent talks, and we'll see you back here in about 20-25 minutes.